Yes, and I'm chair of the committee. And members of the committee present this morning are councillors Paul Panda, Owen Jeffrey, Alan McCrow, who today is substituting for Nick Carter, is that
Nick Carter.
You were substituting. David Marsh, Stephanie Stevenson, and Joanne Stewart. And I'd like to welcome our new members who are here for the first time. That's David Marsh, Joanne Stewart. Yeah, and Paul Panda. Okay, thank you very much and welcome to you all. Councillor Heather Codling is also present as chair of the Health and Wellbeing Board. Thank you for attending, Heather. Council officers and external partners join us to advise and support the meeting are Paul Coe, Executive Director, Adult Social Care and Public Health. Anne-Marie Dobbs, is she? She's not here today. Melanie O'Rourke and Green, and Service Director, Adult Social Care. Matt Pierce, Director for Public Health, and Jamie Evans, who is on our screen here, and we're hearing from you later, Area Director, Health Watch for Berkshire, and from Rural Berkshire NHS Foundation Trust, Sally Moore, screen here, and Head of Communications and Engagement, and Georgina Potter, from Buckinghamshire, Oxfordshire, and Berkshire West Integrated Care Board, Sarah Cavell, Associate Director of Nursing, Daphne Barnett, Interim Associate Director of Nursing for ICB, Steve Golden-Smith, Associate Director of Prevention and Health Inequalities, and Helen Clark, Associate Director of Place, Berkshire West. And Vicky Phoenix is the clerk for the meeting. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that this morning's meeting is being held both over Zoom and with the councillors present in the Roger Croft room with Berkshire Council. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. We've just had the fire alarm, which is the routine testing. So if we hear any further fire alarms, you must leave the building immediately via the emergency exit to the assembly point in the Dolphin Park. And if the lockdown alarm sounds, and we've just heard that, we will await instructions from the officers. We'll adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted? Vicky, do we have any apologies?
We've received apologies from Councillor Nick Carter, and Councillor McCrow is here as a substitute, and we've also received apologies from Councillor Dennis Benningworth and Councillor Martin Colston.
So item 2 is the minutes. Can we confirm the minutes of the Health Scrutiny Committee? We've got 2 sets of minutes held on the 11th of March. These need to be proposed and seconded as a correct record. As regards matters arising, we'll be discussing the actions that you see on minutes in item 3, so we don't need to discuss that here. We're just looking for accuracy. So can I have a proposer? Councillor Jeffrey? Councillor Stevenson? All in favour? Not many of us were there. Yeah, you're there.
You don't have to be there to adopt. We're adopting them.
Well, okay, thank you, Councillor Jeffrey. Right, so that's okay. So then we have the minutes of the Health and Adult Care, Social Care Scrutiny Committee. That's going to be changed on name, held on the 15th of May. These need to be approved. Can I have a proposer? Councillor Jeffrey, and the seconder, Mr. Stevenson. All in favour? Very much. Okay. So now we move on to actions from those minutes, which are on page 13. So the main item, one of the main items we discussed there was looking at oral health and dentistry, and we had a very detailed discussion about it. And there were several actions coming out of that meeting. The first one was looking for data on tooth decay extractions. At the moment, that doesn't seem to be available. Can you tell us what the problem is with that?
Well, the next oral health survey on 5 years will take place next year between January and May. So I think the committee might remember there's quite a big gap between the last survey. So that's going to take place next year. So then I'll imagine middle to the end of next year, that'll be the latest data we get on tooth decay extractions. We have just undertaken a survey for care homes and older people, and we're expecting that to be available early next year as well.
So we're waiting for...
Yeah, it's normally every 2 or 3 years some of these surveys take place. It's a bit of a delay in
Okay, so, well, thank you. All right, that explains that. Thank you very much.
Page 35, we have some data regarding children and dental. So we have 475 children waiting a new consultation and 13 to 14 weeks wait. And then we have 160 waiting at the Royal Berkshire Hospital, 6 to 7 months wait, and Buxton Park's even worse. And the general needs is a 9 to 10 month wait, so we do really have a big problem there in children's mental health.
Well, we do, yes, and you see that action 36 in the minutes says that we were requesting an oral health needs assessment, which is because of these concerns.
What I'm trying to say, Madam Chairman, is that I think this is a really urgent thing to look at.
Okay, so I assume you're saying that because we proposed that we needed an urgent survey. This is why you're expressing that quite strongly. Yes, Councillor Stevens?
Can I agree with Councillor? Because I know that we could put everything and say it was a priority. I think there is a tendency to forget oral health. And you and I were discussing how it's been linked to dementia.
Yeah.
And you know, it is far more concern than perhaps we imagine. So can we keep it up?
And there's also a link with cardiovascular disease.
Yes,
there is. Yes, so we did express our serious concern, and I think we stand by probably, obviously your decision, you need for a oral health needs assessment, but your note says that obviously this requires resource commitment, so we do need a formal recommendation of this committee if we want to go ahead with that. And we've also had some comments from our Director of Public Health, Matt, who's here today. So we could make the recommendation today that we want the oral needs survey, or we could postpone it until our December meeting when we are having further, this matter comes back to us for further review. We probably will have had the information about the elderly peoples.
Well, that will be till next year.
That's not till next year. Okay, but so there won't be any further information when we come to our December meeting. So we'll still be looking at the information that we've got now. So that's not a reason to postpone it. So I think I got a note that I thought it was due in December, but no, it's due in January. So we have had a comment. I don't know, you want to comment further, Matt, that you think there might be other priorities.
Well, yeah,
There are other priorities.
There's lots of public health priorities, and Councillor Coling will know is one of the things we're doing at the moment is reviewing the Health and Wellbeing Board through the LGA, and that's been completed now. And what we'll be looking to do is actually review our priorities as a Health and Wellbeing Board. So in September, the view is that the board will have a look at all the different issues that West Berkshire are facing. And through that conversation, looking at the data, recognising not everything can be a priority. Board will then discuss about, what are the things we'd like to focus on over the next 12 to 18 months. Ideally, they're looking at 2 to 3 priorities because clearly there's huge issues across a whole breadth of different public health priorities. So, that it might well be that oral health comes out as priority. I don't want to second guess what that might be because it's down to partners. Health and wellbeing is a partnership ultimately. So we need to come together to say what these things are. It's worth the committee knowing that conversation is underway, and that will probably take place around September time.
What, September the what? Because we've got a meeting in September, so when it's
so we're looking to kind of hold a workshop around September time, and they'll be reviewing a rapid state of the district report, a joint strategic needs assessment, again, look to all the health issues. So whether we decide in September exactly what those priorities will be, I don't know. It's probably a 3-hour session, but definitely this year, hopefully we're going to identify those 2 or 3 things. I said it might be all health, it might not be. It's really difficult because everything's a priority to be discussed.
Another possible consideration for postponing it, although you might not think this is a serious one, is that we have got new members who didn't take part in the discussion that we had, although you've got all the details in the minutes and hopefully you've had a chance to read the minutes. Councillor Marsh.
I didn't mean to interrupt you. You're right, but I mean, it was reading the minutes and reading the report that kind of shocked me really on this issue, especially as a parent of a relatively young child. I mean, Councillor Stevens is right, it affects elderly people, but I mean, if they've got these problems at the age of 5 to 9, then that's a lifetime of rotting teeth or whatever the issue is with them. So it seems to me it should be a priority. I mean, I'm new to this committee, but I think.
So we feel quite strongly that it should be a priority.
That's what Macro has suggested.
Yeah.
I'm just going to say, just looking at dates in September, if we were hoping that it might be a case of we would be able to have the Health and Wellbeing Board and make those decisions and then come to scrutiny, actually it's the other way around. We've got scrutiny on the Tuesday and Health and Wellbeing Board on the Wednesday. So if those dates are to stay as they are, we won't probably.
I think it's being discussed in September at the Health and Wellbeing Board.
Yes, but the two meetings.
Well, we're bringing it back to December, so we'll be postponing the decision to December, not September.
Okay.
So
You mentioned September, so I was just making it clear.
Yeah, thank you very much. So so either we decide now, we vote to make this a priority, and we think it's a serious matter, and we do, or we wait and hear further information about the other issues that might come from the Health and Wellbeing Board. Yes, Councillor Jeffrey.
I think somebody made the comment, didn't they, that everything's a priority. But I think we were all a bit shaken when we saw the report last time. And I had not picked up on what Councillor Stevens was saying before, that medically it could be related to all these other conditions later in life, etc. So we're not just talking about whether the youngsters have got decent lashes for their grub when they're young. And I think on balance, I would suggest, I can't formally propose that we do make it one of our priorities.
So you'd like to propose that?
Yes, I would.
I have a seconder then? Councillor McRae.
Yes,
Councillor March?
Are we voting to make it a priority, or are we voting to?
We're voting
for an oral health needs assessment.
Yes, we're voting the oral health needs assessment, and but we see this as a priority, but we think they should. We're voting on that oral health needs assessment. Yes, sorry, that wasn't very clear. Okay, so we've got a first and a seconder. So all those in favour? Okay, thank you very much for that. Thank you for that clarity. We accept that, but there are other urgent issues. So I think this is something.
As an observation, a bit like mental health is one of these things that kind of keeps getting forgotten, put in the background, and actually then you end up with a really big problem because you ignore it.
Well, we have. I mean, one of the priorities.
When I say you, I mean that.
One of the things Matt is concerned about is mental health, and we have looked into that, and that will be coming back again. So we do accept that as an issue, but I think it's where the resources go, I think, is your concern, because they are limited.
Yeah, I mean, the resources from the Health and Wellbeing Board, also the Public Health team. So just because it's a priority, not the Health and Wellbeing Board, it could be as a Public Health team, we might be able to take that forward. But ultimately, these require partnership. It's collaboration, not one single organisation can often solve these problems. So if it was a priority for the board, then that would carry a lot of weight with partners, because they then have to devote resources to improve it.
Sorry, I was just going to say, that's part of the reason why I want to come to these meetings. I'm not a member of the board, but I can listen in and see what your priorities are, and that will colour our decision when we get to Health and Wellbeing Board. It will help make the decision, and those that sit on both, or even if you come along to the workshop, it will be useful background for me.
Well, thank you for that clarification. The other action there is action 37, which is about sort of working with our partners through this debate, and we do recognise that there are things that are going to delay that, particularly with the proposed Bob reorganisation, which we're only just hearing about, and we do see that it's going to affect probably a lot of things. So we're waiting for information on that. Okay, so we move on. Then we've got so thank you for that discussion. Yes, Councillor Stevens.
Could I bring up one thing from the minutes?
Yeah.
We were told that we're going to get this new provider, Embed, is taking over from the ambulance service for non-emergency patient transport services. And we're going to speak to them again, but not till next March.
Yeah.
And I did wonder if we could just make contact. Vicky suggests to the ICB just to ask, how is that transition going? Because we were very impressed with
They were. Yeah, it was amazing.
the ambulance service.
The figures and
Very
morale
impressed
and
by
everything.
her.
Yeah.
And I'd just like to ask, how is Embed doing?
Can we just get a sort of just a response between meetings? Yeah, just to show our interest.
It's informal to show interest.
Yes, and to show that we sort of noted.
We're following up.
And we want to follow up. Yeah, that's a good idea. Thank you very much, Councillor Stevenson. Okay, right, can we move on then to item 4, which is declarations of interest. So do members have any declarations of interest related to items on the agenda? Councillor Stewart.
Yes, so there are going to be some standing declarations of interest for me, which I think you will add to the agenda for future meetings. The first one is that my spouse is head of contract management at the Royal Berkshire NHS Foundation Trust. And the second one is regarding myself. So I'm employed by the Royal Berkshire charity as a fundraising manager. Although the charity is a separate entity from the Royal Berkshire NHS Foundation Trust, there may be occasions where it would be inappropriate to take part in discussions of certain topics. And that we've taken advice from our monitoring officer. So item 9 on the agenda, I will be stepping out of the room and I won't take part in that discussion.
Thank you for that, Councillor Stewart. I mean, it's good to have you on the committee, and it's a shame we can't sort of get some information, but never mind, we can see the reasons behind it. So thank you very much for that clarification. Oh, got everybody on the screen. Thank you, Vicky. Okay, that's all sorted. And I'd like to welcome Councillor Patrick Clark. Hello. Thank you very much.
Thank you. Sorry for being late.
No worries. Good to see you. I haven't got your name in front of you.
No.
And your title is?
Cabinet Member for Adult Social Care and Public Health.
Public Health. Thank you very much indeed for attending. Okay, so item 5 is petitions. So have you got any petitions, Vicky?
No petitions have been received, Chair.
So we move on to our first item, item 6, health inequalities. So we have Steve Golden-Smith, wonderful name. Okay, Associate Director of Prevention and Health Inequalities, and for Bob, ICB, he's going to give an overview of his report, which you have in your plans. So over to you, Steve.
Thank you, Chair. Can I just check that everyone can hear me okay?
Yes.
Yeah, excellent. Okay. Okay, I'll have a few slides to share, which I will go through, so I'll double check they're coming up, but thank you. Yeah, so my name's Steve Golden-Smith. I'm the Associate Director for Prevention and Health Inequalities at Bob ICB. I'm just going to bring up my slides now, and hopefully you can see those. Are those visible to you?
Yes.
Yes, thank you.
Excellent. Okay. Okay, so right, the NHS play a role in health in 4 distinct ways. So I'm just going to give an overview of what we do as NHS and ICB, and then go through some of our priorities. And I'll probably touch on some of the things you just had an early discussion, because I think included in my slides are mentions around dental and something around mental health for children as well. So we'll touch on the areas we know there are challenges in the system, but challenges in the system that have a health inequality slant on them, as well as a general access issue. But so we can play a role in tackling health inequalities in 4 different ways. We can work in partnership very much with organisations such as yourselves, local authorities, police, fire, a whole range of other organisations to try and influence and challenge and advocate sort of the wider determinant issues that affects people's health. Quite importantly, we can work as an anchor organisation. This is how we deliver the services we do, how we purchase them, how we commission them, the way we employ. So making sure our employment reflects the sort of the makeup of our society, make sure we're reaching out to those areas where we want to encourage recruitment from. And again, looking at how we actually use a wider influence of our organisation to benefit our local community. I think very importantly, we have a responsibility for the services we actually deliver, and excuse me, excuse me. And we have sole responsibility for these in many ways. It's about how we actually continue to deliver a high quality care for all. And we can take sort of real sort of immediate steps on those areas, depending on the priorities and the resources we have. But it's an area of our control, area of our influence. But as health inequalities go, you might be familiar that health itself is probably related to about 15 to 20% of people's health overall. There are lots of other things that influence people's health. But if we can ensure that we get our own house in order, that we deliver care as best as we can improve access, we can improve experience, we can improve outcomes across the piece, then we can have a really good impact on health equalities themselves. When people aren't well, then their ability to manage their lives and remain sort of active citizens is extremely undermined. And then the fourth one is a very much a collaborative focus on ill health and ill health prevention, and healthy lifestyles. So typically this is the sort of how do we encourage and enable people to manage their lifestyles in a more positive way, whether that be weight management, whether that be reducing alcohol content, whether it's increasing exercise, smoking, but also a whole range around social isolation and things like that. We can have a really strong role in that by encouraging, signposting, referring, and explaining to people why it's important they do look to make changes within their lifestyles. Typically on a health basis, we get quite clinical. And these are just a couple of figures about some of the issues within West Berkshire that we sort of understand about how West Berkshire itself is sort of perceived in its clinical profile area. And you can see the red boxes there on the table I'm showing, which has got the circle around West Berkshire, and that's where there is an above average type of instance of AF is atrial fibrillation, hype is hypertension, asthma, which I think you probably know, cancer, dementia. So those are where we see our clinical areas where we have some concerns in the West Berkshire area about why there is increased rates of those illnesses, and often behind those lie a lot of the drivers for health inequalities and poor health. So a lot of it is lifestyle behaviour. It is your smoking, it is your exercise, it is your alcohol consumption. It might be the environment in sense of pollution. But a lot of the drivers for that are sort of health inequalities linked. People living in typically more deprived areas have poorer access to fresh air, to exercise space. Their health behaviours are often different for various other drivers. So many of the issues we see within that area, including say asthma and hypertension, are driven by those sort of wider determinants that we see, but not all. So these things take place across all society, but you will see higher prevalence in areas of deprivation and populations of concern. We have a couple of priorities set for us sort of nationally, and you might have heard of the Core 20+5 programme. The Core 20+5 programme exists for adults and it exists for children. The Core 20 is the most deprived 20% for the country. The plus is a sort of a fairly ambiguous group, but largely it's defined at those populations of concern or priority. And within our area, we are looking at largely inclusion health groups, which are your Gypsy Roma travellers, your homeless, your asylum seekers, a whole people experiencing mental health issues. That was where we typically include in our plus groups, but that does vary from place to place and definition, but it gives us the flexibility to sort of think where some of our main concerns are. And then the 5 are 5 clinical areas. And for adults, we've got maternity, mental health, respiratory disease, cancer and hypertension, which you'll see relates back quite closely to those areas of concern that we have within the West Berkshire area. So within those 5 areas, we are supposed to be ideally focusing on the most deprived areas of the community. We are supposed to be ensuring we focus on these 5 clinical priorities and trying to mobilise resources, improve access, experience and outcomes for each of those areas. It gives us a few challenges in Bob, and it gives us some more challenges back within West Berkshire and Berkshire West Berkshire, in that often the numbers of people defined within this Core 20, the bottom 20% of England, is quite small. So our plus population we've taken as those inclusion health groups, but we've broadened it to ensure it's sort of the local areas bottom 20, bottom 30, bottom 40%, and that can grow and shift depend on resources and focus. But you see within West Berkshire, the numbers of people in the IMDs 1 and 2, these are the lowest, are quite small, and they're contained very much largely within 3 GP practice areas. If you expand that to 1 to 4, the bottom 4, then the numbers again do go up, but not significantly. So you might throw within our Bob ICB, we have just over 2 million people now in our ICB, and within the West Berkshire area, 4,000 of those are roughly within the bottom IMD4s and in those practices. But what it does allow us to do, once we now start to identify those areas, is to start sort of working out those populations are concerned. So what we've been doing over the last couple of years and longer is working to improve our data collection with partnerships with yourselves, pulling in information from hospital data, GP data, adding that to local authority data to get a much better understanding of the cohorts of concern. And this is the adult overview for what it looks like for West Berkshire. And you can see the numbers in each of on the right-hand side in the deprivation decile. You can see some of the plus communities. And I have to say, I have to caveat there is some concern around some of the data quality of this. It's not totally accurate. This relies on coding within primary care and hospitals and other areas, which we know isn't totally 100%. But it gives us a broad indication of where we should be looking, the type of work we should be looking at. And it gives you the numbers of the people within the West Berkshire area with cancer, COPD, hypertension, mental health who have been pregnant in the last year, which relate to their 5 priorities. And the round circles that overlap each other, the Venn diagrams, again allows us that more clarity to see where there are overlapping relationships. So how many people who are homeless, for instance, have cancer and COPD, maybe it's with asylum seekers. So we can drill down and segment our cohort so we can actually target more focused work. Similarly for children, so exactly the same terminology regarding the core 20, most nationally deprived 20. The plus group varies, and I'll show you on the next diagram how the plus group might be different. But the clinical priorities for us to look at are asthma, diabetes, epilepsy, oral health, which you were talking about, and mental health, which you were talking about. And so for each of these 5 and the 5 above, there are activities within the ICB and health services trying to get a better understanding and to try and deliver some changes within those clinical pathways for those areas. Looking at the figures for children, we can see again the numbers are actually smaller than they are for adults, and the plus groups are defined differently. Now we can manipulate the cohorts for that within the plus, so we can look at a whole different groups and whether it's relevant to be looking at households with obesity or households who are overcrowded or with a carer. It's a definition of where we feel the relevance and the importance lies. What it does allow us to do is to understand where those cohorts are, and then working through our GPs, through our communities, targeting those individuals, ensuring we are sort of in touch with them and encourage them to access services. And that access of services is really important. Often and we'll pick this up in dental. So the access, the experience of and outcomes of services provided by health are influenced by many different things. But typically, clinically, once you're in the system, then deviations between groups is quite minimal. What we do see is the access issue can be a challenge. People don't know what to do, how to approach, or perhaps don't trust, and many other reasons. Once they're in the service, their experience can be very different in the sense of how maybe their health literacy, maybe their language, maybe their understanding, maybe even their financial ability to attend services can change. So their experience of the service can be influenced by their personal circumstances, and the outcomes as well. Some people's outcomes are very much influenced by what the society they go back to. So, for instance, discharging homeless people back onto the street isn't seen as a positive thing. They should be going back into accommodation. So access, experience and outcomes are how we typically look at our services. But clinically and time-wise, once you're in the services, there's actually limited sort of variation at times between services. I picked up these areas within the children's work that we're doing because I was asked to come and talk largely about the under 5s, under 10s. We don't typically do anything for under 5. It's not how we break things down. So our services are sort of generic or aimed at children under 16, under 18. And these are the activities we've got going on in West Berkshire. We've got an asthma pilot in the Royal Berkshire Hospital, trying to improve the quality of care and access to services. Very similar with epilepsy. We've got an epilepsy nurse specialist who's developing their services, training staff, again, improving the quality of care for services. And diabetes relates to sort of access to pumps and insulin pumps for children. So there's work going on in that area too. For dental, I think the figures you quoted were very similar to the ones I've got here. We're aware of the challenge that presents, and we've done some work regarding some community engagement through the health watches and organisations looking at the dental issues. We've done some really interesting work through health watches, engaging their communities to understand what the challenges around dental is. It very much is an issue which has two bits. There is a general access, but there is a specialist access for people, children who are neurodivergent. And there's a real challenge in that about the way that they are able to access and use dentists, in the sense of there is huge anxiety in going to the dentist, maybe even having to go under a general anaesthetic even to have a dental review. So it's really challenging. It's not just about is there a place or not. It's the appropriateness of the place, whether it can be delivered in the community, whether there's a need for hospital waits. But we know there is a challenge within that area, and one of the areas we're trying to improve is that rate of access. Mental health, again, we are pretty clear that the ethnicity profile actually isn't that adrift to the West Berkshire population, but we are improving our data now to ensure where there is unwarranted variation, we are aware of that, and we can begin to take some actions that address that. Being convinced that inequality is a golden thread throughout the whole programme, so they are making sure that they are addressing inequalities where they can, and so they don't provide mental health to 6 under 5s. As I said before, it's a more general area. So our data tells us there's no major inequalities in ethnic groups for young people. We are targeting work in particular areas, and in terms of deprivation, there does seem to be a correlation between the level of deprivation and how likely referrals are to be urgent. So what we're seeing is people are slow to come forward, and when they come through, it's in crisis. So not necessarily reaching out at an earlier time, when perhaps we could do some sort of slightly less invasive, more rapid interventions to decrease the matter. But we also know that our deprived patients will like to be seen quicker, and that is often due to the urgency of the nature of the presentation. So inequalities is interesting in a number of ways. We can be geographically focused. So I talked about the areas of IMD, those areas of deprivation. We can be population specific in the sense of whether it's ethnic minorities or women or other groups, and age, for instance. And it can be sort of in groups like inclusion health groups I mentioned, such as homeless and mental health and asylum seekers. So we can take a cut by those. I mention that because what we often find is that the levels of quality, level of experience of our outcome vary between those cohorts. So the inclusion health groups, for instance, the homeless, mental health, asylum seekers, their sort of average life expectancy is probably 10 years or so, maybe 15 years below the more deprived areas, and those more deprived areas can be 10 years below those more well-off areas. So depending on how you cut the data, depending on what you look, depending on your focus, we can see quite extreme ranges in difference between health outcomes. The Berkshire Community West project, the Community Wellbeing Outreach Programme, I can see Helen's here today, is one of the things we're trying to do to encourage greater access to a whole range of communities. It's built around the NHS health check, but we've broadened the access. The NHS health programme is open to 40 to 74s, but we've broadened that to 18-year-olds plus. And it targeted those specific cohorts I've just been talking about. The intention is to try to engage those communities that, for various reasons, aren't necessarily purposefully or regularly engaging in healthcare. There is lots of barriers to that, whether it's poverty, whether it's general access, whether it's time, whether it's trust, with a whole number of reasons. And the Community Wellbeing Outreach Programme is trying to sort of ensure where we can, we are engaging with residents in a more timely, more early phase, and encouraging them to become more participatory in their own healthcare and taking much more of an active role. Over the last year and a half since it's been going, we've seen the number of delivery sessions of this taking place. And in West Berkshire last year, there was like 446. Sorry, there was 446 sessions delivered in West Berkshire. Of those, we see an attendance rate of around 2,500 people, roughly split 50-50 between male and female. And it's been seeing a progressive and positive impact that we're seeing now in those numbers. Which is proving really important. We're targeting communities, as we target them at the areas of most deprivation. We target it from an ethnicity profile where we can. We target it from where we know there are poor people who haven't necessarily engaged in health services for over 12 months. And typically the most regular cohort, should we say, for West Berkshire is that 30 to 39-year-old. To actually get their involvement is actually quite positive. Many of these people are working, so time is difficult for them. The outreach seems to be working very well, taking services to them through trusted providers and partners, and ensuring where we can people are accessing that service to get that health check, to allow that health conversation, and to ensure that their weight, their hypertension, the vaccine status, a whole range of things is as up to date as we can get them. And you can see again that we're actually targeting the right categories that we wish to. What we're finding is that hypertension and BMI are the two, high cholesterol, BMI and blood pressure are the 2-3 main areas within this area. So people that are coming for their checks, we're finding quite a significant proportion of people who are overweight and therefore have high blood pressure, some because they are overweight, others because they have high pressure per se. And that's reflective of lifestyles and understanding and active involvement in maintaining and looking after yourself. It's that long discussion about what can you do for yourself to ensure that you are reducing your needs for health, social care in the future. I think we all know that being active, being of good weight, not smoking, not drinking, having good social groups, getting out and about, paying attention to your health and mental health is really positive in the short term and the long term, and as we go into our later years. Many of the things that we're advocating from a prevention and a treatment process throughout the clinical pathway should aid and abet people in later life and reduce the need for social care inputs, and even reduce the levels of dementia in the community. So the very simple conversations we have can be quite life-changing. People can take a real active interest in their health, to reduce their weight, to watch their diet, to improve their exercise, to get that balanced social life, and therefore hopefully reduce their likelihood of services in the future. Obviously, there's not much we do for those sort of areas, but actually that encouragement is really, really important. So what we do, we start to refer people to known services, so that's smoking services, through like loneliness and isolation services, mental health services, to try and encourage people to participate and become active partners in their own healthcare. A bit more detail around the type of services we're referring to in West Berkshire, and again, it just goes back to look after yourself in the short term, the medium term, the long term, provides those best results. I'll finish on a couple of slides around immunisation. This is really important, and these are the COVID vaccine summary slides. What you're seeing across West Berkshire is a pretty average standard uptake of the COVID vaccine. This relates to the spring update, the over 75, as I want to say. So this relates to the spring vaccine, and so though we get a really good uptake, when you start to drill down into areas of deprivation, you can see lower levels per that. But when you drill down into ethnicity, you can see quite a startling change. And some of the barriers to this are really, really complex. I think it's well known that COVID had an unprecedented impact on areas of deprivation, but it has a really high impact on people from ethnicity. And it was felt that those people from ethnic backgrounds were more vulnerable, more likely to catch COVID, more longer to have longer term implications of it, and be more likely to die of it. However, that's not reflected within the vaccine uptake. So the challenges around access, the challenges of engaging communities to improve their COVID vaccination rates is a real issue. And I put it on here because it's just one of those areas we all continue to work at in partnership with yourselves, in partnership with communities, to try and improve and educate and hopefully increase the rate of uptake and reduce the long-term implications and potential deaths that COVID still has, though not thankfully as great as it had been a number of years ago. Within the childhood vaccination, this is my last slide, so sorry. This is the childhood vaccination. We do see some interesting areas, and so the top left-hand square is the most affluent deciles in your area, And there we can see the contrast between the most affluent and your least affluent wards in your area. And it's pretty marginal, really. And also, really valuably, what we actually see in the more deprived areas, there is increased actually uptake for some vaccinations. So it's not a lack of interest and it's not a lack of concern, but actually there's some really sort of positive response to that. But again, we start to see how it can change as well. So when you look at ethnicity, again, there is some change between people from ethnic backgrounds, white backgrounds, sorry, compared to ethnic backgrounds. That's more extreme. So there's something there around, again, how do we ensure we are engaging with our communities so they are fully informed and fully engaged in the service. And I say the last one, 0 to 9 as well. It's again the difference between the ethnicity and the BAME, the Black and Margie ethnic community, sorry, in the 0 to 9, where again uptake is less, not substantially, but it is less, and it's an area we'd like to very much improve. We just stop sharing for the moment. I've covered an awful lot of ground there, trying to give you a broad snapshot of the type of work we're engaged with, but I'll be more than happy to take any questions or
Thank you very much, Steve. Thank you for going over your report, which is quite extensive. And before I ask members for their questions, I wonder if Matt, our health director, wants to comment or raise any particular issue.
I've got lots of questions, but that's for the committee to ask. I think it was more about, I think a lot of what, and thanks Steve, that's really helpful. A lot of what Steve talked about is about being in partnership, what I was alluding to earlier. A lot of the community outreach work is obviously delivered by public health in partnership with Solutions for Health. I think Steve makes some really good points about deprivation and correlation to disease conditions, life expectancy. I think going forward as an ambition for West Berkshire, we really want to get that granular level data, so ward level data, and actually understand where those hyperlocal issues are, if you like. And that's something we want to take forward as we review the joint strategic needs assessments, that document that informs the work of what we do, where the issues, where the needs, where do we want to focus on.
Very much for that. Members, yes, Councillor Jeffrey.
The business about, I'm sure we've all probably been aware of it for many years, but people that are in more deprived categories are the ones where the childhood vaccinations don't with the biggest speak for themselves on the graph, don't they? But what is it that has been done to try to get those figures up, and what is it that we can be urging, recommending whomsoever to do? At the end of the day, if you take your child to the doctor and they vaccinate them, that's its job done. How do we actually get to the people that are not taking their child to get the rubella and the rest of it?
So just to do with vaccinations, Councillor Jeffrey?
Sorry, yes.
Just vaccination. Okay. Steve?
So how long have we got for this discussion? Because it's something that's been perplexing minds for quite a long time. An awful lot has been done to try to support, engage, encourage, explain to the communities we have concerns about the benefits of vaccination. We've worked through a lot of local communities and the community leaders. There's been things done at a local level. We've taken services into communities, so to cut travel time down. We've changed times and broadened times so people can access them. It's been supported by a lot of national communications and information, but we have still struggled in the ethnic minority community largely, I would say, to get the uptake that we want. And there are lots of reasons behind that. Some of it is trust, some of it is understanding, some of it is seen as racist attitudes that have existed for a number of years. And some of the beliefs and behaviours of those communities in how they have engaged with services have always been problematic. With that element of trust, that element, it's for them, is an extremely complex and difficult one to get over. And I don't think anyone has really cracked it. We've done a lot of practical stuff to make it easier to access. We've done a lot of explanations so it's easier to understand, but actually driving up those numbers continues to be a problem. And it's not just a Bob issue or a West Berkshire issue, it continues across the place. What we do know is that where there is really a good example of good practice, where it is delivered in the community through community trusted venues with community voices, community engagement, community participation in that, things improve, but don't improve perhaps to the levels that we would want them to. It remains a real challenge for whatever, especially in the COVID vaccination, particularly the other slides, the children's vaccinations, less of an issue, but it's the COVID vaccination ones that is a stark standing out.
I think the children's figures are a bit of an issue, because you've got to get up over 90% for your vaccination to be effective, and a lot of these figures are not over 90%, and we've still got.
Yeah.
Can I just ask? Health visitors used to be quite crucial in asking questions and giving people information about vaccinations. I mean, they're not giving it, or they're used to in some cases where people couldn't access their surgery, or for one reason or another couldn't keep appointments. You had a health visitor actually going and vaccinating the children. I don't know whether that happens anywhere at all now, and they were trained to do this. So, you haven't mentioned health visitors at all, or that sort of practice?
I apologise, because I was one many years ago, so I should have done. So that's a very amiss of me. So apologies. I could talk to public health about this, because the public health are the recruiters of health visitors, and I'll probably look for some support in the room on that basis. I'm afraid we know we are delivering vaccines across the area. I have to admit, I'm not sure the role that health visitors play in vaccinations now, and I'm not sure if that's
information a big one. Just giving information, the actual giving
information. Yeah,
and people have questions and they trust the health visitor. Whereas a word from above, sometimes they will query. Yes, ma'am.
Sorry, Steve, I don't know if you've seen it, but the new urgent and emergency care plan 25-26, NHS England are talking about trialling health visitors, giving out flu vaccinations. So I know that's new, but that'll be in some selected areas across the country. But generally, we do, they provide a lot of advice about vaccinations. That's really important.
They do, really do. And I think that, with, again, COVID influenced the face-to-face stuff, and I don't know whether our health visitor numbers are as what they should be, but I mean, thank you for that information. That's very interesting. Okay, thank you for that answer. Councillor Crowe?
First of all, on the health visitor issue, I was reading about this programme that's in the past. Seems a shame that it's going to be limited to flu. One would have hoped they would include MMR as well, because
what you mean? You've heard of just a class on flu?
The idea that health visitors would actually be doing vaccinations.
Health visitors are mainly working with children under 5, so they're talking very much about early years of visiting.
So that's what I'm saying.
Yeah.
The MMR figures are rather lower than some of the other vaccination numbers. I mean, that has been a big problem in measles just recently. What I'm saying is, if they're going to offer flu vaccinations, then perhaps they ought to offer MMR as well.
Oh, I see. You mean the giving the vaccination was about flu? Okay.
But that's my question. I had 2 questions really. One was about the prevalence of various health conditions at the beginning, and I noticed that some of the figures for West Berkshire are rather worse than the other authorities. And particularly, I was a bit surprised that asthma and COPD is significantly worse than Reading.
Yes.
Now, Reading suffers quite a lot from traffic.
Whereas
I thought the air in West Berkshire was comparatively fresh. So I'm a bit surprised at that. And I wondered if you had any idea why that might be the case. The other thing is that the community outreach programme, which I think is a very good programme, I noticed the uptake, I think it was an average of about 5 per session, which seemed rather low. And I wondered if we could do rather more to try and increase the numbers taking part.
I mean, Matt wants to answer your question, but I was going to just comment on, I wondered where the community outreach takes place. And I did see a few weeks ago, I saw a van parked in a very obscure corner of the car park at West Berkshire Hospital, obviously trying to do some outreach. And it just had about a large number of what looked like the professionals. Because I went over and talked to them. None of them were patients. accessing the service. They were just standing around chatting to each other. So I mean, I don't know whether that was meant to be community outreach, but it wasn't really very well thought out and expensive from the point of view of who was there and what they were doing. So, you know, you should be, for outreach, you should be going into the pubs. You should be going into centres where people meet and not just going to GP surgeries or something like that. So anyway, Matt stuck his hand up to respond to something.
Yeah, just on that data, Steve, similar to your point, I was quite intrigued because.
Oh, thank you. Is that all right? Doesn't sound like.
Okay. Yeah, so Reading and Oxford, the most deprived communities, actually benchmark really well across nearly all metrics. And then I wondered, is it possibly because West Berkshire are more health literate and better in terms of getting diagnosed? So I'm just curious about whether there's been any interrogations on that data. So it's very surprising that Reading and Oxford are green on nearly every metric.
As far as I'm aware, and Helen's on the call now, she might want to come in. The full evaluation is yet to be sort of taken place. We've just been reviewing the sort of the numbers that we've had in, rather than perhaps the reasons behind them. So I'm not able to really answer that question. Helen's got a hand up now, so perhaps she can provide update, because Helen is the West Berkshire obviously area, and that's where the programme sits under. The health inequalities funding comes from sort of my team area, and it's delegated over to Helen and her team for that programme.
Just before you bring
Helen, can I bring you in? Yeah.
Yeah, I was referring to the prevalence data on I think it was the first slide you showed, not the community wellbeing outreach service, of prevalence of CBD, cancer, depression. Yeah. I was just saying Oxford and Reading are green on all metrics, which surprised me. So I was just curious to know whether anyone's looked into that.
Can you say that again, Matt? So I didn't quite hear.
Helen, do you have comments on? Helen? Are you commenting on this? Hello, you put your hand down. Hello. Helen, can you hear us? I think you're muted.
I think she's frozen.
She's muted. She's
moving.
Can you unmute? Can you hear? No? Oh, there you go. There. Okay. Can you hear us? We can't hear you. No. Oh dear. What's going on there? She's gone altogether. Maybe she's going out and coming back in. Okay. Well, while we're waiting, I think they.
Can I just add to what Matt was saying? It's not just that, but if you look at the rural areas, and I was looking at the asthma and COPD as well, COPD is a priority, but they're all green. Whereas the asthma in the rural areas, if you look at Vale of White Horse, South Oxfordshire, they're all in the red along with ourselves. Why is that when you expect the asthma not to be that bad?
Well, because of the
rural area.
Asthma isn't just about pollution. It's hereditary.
Yeah.
It's
But it would
But
be
also the
exacerbated.
fields as well, right? Spraying, crop dusting.
Yeah, maybe. But that's the question.
And that's the problem with stats, right?
That's a good point. Yeah.
Damn lies and statistics, right? Yeah. Because I was going to ask the question on the COVID stats, which is there a correlation with take up of the flu jab? Because is it a distrust of COVID, or is it actually people just not doing that kind of vaccination?
Just suspicious about vaccinations in general, you mean?
Well, of the COVID vaccination.
Particularly the COVID, because they relate it.
So, for instance, if the same people were having the flu ones,
Yeah.
but not the COVID one, was it because they distrust the COVID, or is the number the same? And again, that comes down to drilling down on the stats, right?
Yes. Yeah.
Because I know a lot of people who would gladly have the flu one, but not have the COVID one anymore.
Yes.
I mean, there's multiple reasons for this. COVID, porcelain, gelatine. People with some background didn't want the vaccination for that reason, because they thought it contained that, not that it was about it not being effective. MMR, there's Andrew published something, got his surname, many years ago about MMR and autism. Yeah. So it depends on the vaccination, but there are correlations, sometimes people myths and facts, and we worked really hard during COVID. The only way to uncover this is to do some community insight work with our volunteering community staff. And that's where we've probably been most successful in.
But it's not hard. Shouldn't be hard to gather the stats for the flu alongside the COVID. They're typically done at the same time.
Yeah, that's true.
Not, I don't know what it would give us, but it seems fairly sensible or simple to do because they're similar in terms of their outcomes.
I mean, West Berkshire on the whole do pretty well nationally, actually. So there are deprivation and variation between the data, but on the ground, it wouldn't be something I'd see as a huge priority for me.
Yeah.
As a director of public
No,
health.
I get
I'm not
that.
saying it isn't, but it just needs to be cautious of what.
Thank you. I'm aware Matt has to leave at 11 o'clock, so it's good to get his in.
11:30.
11:30. Oh, 11:30. Okay.
Yeah.
David, you had your hand up for a question.
I wanted to ask about ASP, but I think it's been covered by.
That's been covered. Helen, you're back again. Did you have input about what we've been discussing?
Yeah, can I just check if you can hear me first of all?
Yeah.
Yes, we can.
Oh,
Yeah.
brilliant. Okay. So sorry, several minutes ago, I think in terms of the questions, and actually Matt's question related to the general data, and I was going to respond on the community wellness outreach programme. But just to say on that programme, as Steve has said, we're in the process of starting a full evaluation of the first phase of the programme. It will continue whilst we do that evaluation, but that will enable us to really understand the uptake, the groups that uptake is coming from, and identify sort of improvements going forward. And I think with that programme, it's important to recognise, so it's funded by the ICB. I coordinate it at a sort of Berkshire West level, but within each local authority, the majority of the funding is delegated to the local authorities who commission the service. So as Matt has said, in West Berkshire, it's provided in collaboration between Public Health and Solutions for Health as a provider. Outreach-wise, it's in a range of community venues. I'm not sure if the example that you mentioned, Councillor Vickers, was part of the programme or not, but I know Solutions for Health are working in a range of different venues, with including some sort of company venues, also community centres. And again, we're continuing to monitor the sort of impact and uptake across those different community settings. So yeah, happy to bring further information in due course.
Okay.
But yeah, just wanted to really highlight the kind of partnership nature of the programme, because I think that is a really, really key element of it, that we're working together across organisations to try and reach out to our communities through that programme of work.
We have information, say in the council, about where these community venues, where they're coming, where the community outreach is coming, and can we sort of have a conversation if we have suggestions about venues? Is that a dialogue that we have about where you're doing the outreach?
I think we could provide information on the venues, yep, and I'm sure those involved in the programme would be happy to receive input and suggestions around that. We are targeting particular cohorts, so we just need to keep that in mind, and make sure that the settings are appropriate. But yeah, I'm sure that's something we could share more information about.
Thank you very much indeed. Councillor Stevenson, and then you've had your hand up.
Yes, I just wanted to say, as Matt has, that going back to that very nearly first slide with the higher prevalence of conditions, that really concerns me.
Yeah.
West Berkshire's line
Yes.
is practically unbelievable
Yes.
compared to all the others and the national
And we're meant to
figures.
be affluent, aren't we?
Yes, so Mr. Goldsmith, we didn't know anything about this and now we do, now we're concerned.
Yeah.
Now we've seen the graph, you've frightened us.
Well, that's good.
I'm moving.
It could be down to aging demographic as well. So again,
Yeah, okay.
those areas have older populations.
Are you choosing UK?
Yeah.
It helps me care about comparing apples with pears.
I mean, I'll bring you in, Councillor Jeffrey, but I was going to say, when on the very first page of your report, you list the important ways, four distinct ways that the NHS can reduce health inequalities. And yet the one which you have most control over, and the most important one, tackling the existing inequalities in healthcare, is number 3. Now, isn't that the most important one? And isn't that the one that you should be really looking at? You know, about what you can do about these disparities, and about, I mean, we're talking with Berkshire Council, we're having a conversation about doing a health in all policies, you know, looking at everything we do and looking at how it influences health or how it can improve health. So I think, you know, in your own organisation, having what is called a health equity audit, I think you call it, is this something that, you know, I mean, our own people here are thinking, I think the comment came from Public Health, that, you know, maybe you should be looking at this, a health equity audit. Is this something you're considering, something you're doing?
So They're not in any particular order. They're just listed in that order because that's the way I wrote them. So it's not saying one's more of a priority than the other. I have particular views. I do think the what we deliver, what we buy, what we have most control over. So I do think our resources and our attention should focus very much on ensuring that those inequalities in health service deliveries are our priority because they're our gift, really. However, it really mustn't underplay that role in the wider determinants of what drives these health inequalities. So that inequality in healthcare is a quality thing. It's that access, experience, and outcome. And there are lots of work going on within that as we understand where the challenges lie. But the fix isn't necessarily the health service delivery. The fix is about that wider community engagement, that wider understanding, explanation with the communities about some of the challenges in the healthcare. So maybe there are things upstream, downstream, however you explain it, that affect that process that we have to work in partnership to address.
Yeah, I think all the services are there, aren't they? I mean, we've got some excellent services and expertise, but it's not everybody's accessing them. And I think there was a comment on page 33 about people who are most at risk. You know, the higher up the social scale you go, the more likely you are to get access when you've got an emergency. You know, so it's those who shout loudest. So it's very much dependent on the individual, on how much they push their case, whether they get care. So it's making people more powerful, isn't it, really? And sort of giving them support, making it easier.
I use the term health.
Outreach is important, isn't it, really?
I use the term health literacy. I use the health literacy. It's about how people understand and respond to their health. And that varies from person to person, regardless of some demographics in many ways. But yeah, it's what people understand and the actions they take about their health.
So understanding health right from childhood and our education, sort of people understanding how their body works, all that sort of stuff. Okay, Councillor Jeffrey.
It's a very small point, but it is not utterly insignificant. When the COVID and flu jabs were being offered last winter, my local health surgery had, I don't know, 4 or 5 Saturdays or something when they were going to be doing them. And everyone that was available was fully booked when I spoke to them. Yeah. I had no idea what to do. And I walked into my local pharmacy and there was a notice which said, ask us for COVID and flu. I think I was in and out of the pharmacy within about 7 or 8 minutes, including buying the tablets that I got in to buy. And that was having had to go. So I think we do need to emphasise that, you know, I never believed in the pharmacists doing medical work. You know, I was complete, but I've been converted. You know, they literally
they're very useful.
Something which can provide a very useful service.
My own surgery tells people that now they've finished in the surgery, but they go on to the pharmacy. Yes, Councillor.
Just on community wellness outreach service, just going back to that, if you want to talk to someone at council, talk to Kate Toon, who runs that for the council. And just going back to when you made about the numbers of people who you saw at the community wellness outreach service centre, I mean, it does take a long time to do a single checkup. And so if there are 5 people, that I'd say probably will take over an hour. Because there's a lot of discussion, very detailed feedback provided. I mean, it's a brilliant service, absolutely brilliant service.
I think it's a great idea. We will have to move on because we've got other things to discuss. But I just wanted to ask. I wanted to ask a question about your graphs, page 25 and 26. I mean, I'm not. You know, it takes me a while to understand all these graphs and things. So sometimes the information isn't very clear. But you don't list. You list some of the surgeries, but not all of them. So, I mean, we have several surgeries missing. I mean, there are probably more, but you haven't got Chapel Row and Mortimer. You know, why did you cover all the surgeries in when you did this, or is this just an example? I'm just wondering why we haven't got all the surgeries.
You say page 25, 26. I'm showing my presentation, so I don't
number
know
of
what you're
patients
looking at
by
today.
age in national indices of multiple deprivation 1 and 2, and.
All right. Okay. So when you start to cut your population within West Berkshire, you'll see a very, very, very small number of people living outside of the ones that I've listed. So we're talking 2s and 3s at the most. So that's why they're not there. So they are just a very small amount. Your prime surgeries, as we understand them, are the Eastfield, Fort Lyndon, Strawberry Hill, and that increases if you take on the IMD 1 to 4. But yes, very small numbers.
Okay, well, thank you for your presentation, and I think we found that very informative. Do members have any more questions? No, if not, we'll. Oh, Councillor, I'm sorry, Councillor.
Yeah, just to build on Patrick's last point, I just do want to make it clear. This is an area of significant joint work across the council, the ICB, and the voluntary sector, and elsewhere. Okay. The locality integration board, which is the subgroup of the health and wellbeing board, looks very actively at health inequalities as well. So I think it's just to say this is joined up work at the best. I think.
Okay, but thank you very much. I think it really, your presentation, the discussion makes it clear that this is crucial, isn't it, to in our communities, that we've got the services, but not everybody's using them. So thank you very much for that presentation. Okay. Well, we move on to item, is that okay? Okay, we'll move on to item 7, all age continuing care. And we have Sarah Flavelle, Associate Director of Nursing, and Bethany Barnett, Interim Associate Director of Nursing for Bob ICB. Gives an overview of their report, and the report starts on page 47. Thank you.
Good morning. Can everybody hear me?
Yes. Yeah.
That's good. Okay. Just before I start, just formally introduce Sarah Flavelle to you all. Sarah's my successor, so we're working together for June, and then Sarah takes over from me in July. Okay, so that's just to give you the background of why you've got 2 people with the same titles. Okay. I came to see you all at committee in December to address the inequalities that were perceived around all age complex and continuing care, mainly the national framework and the access and delivery of and the outcomes. So that was what I came for in December. At the end of that meeting, obviously, I pledged to work with the teams and across with social care to ensure that those metrics improved by Q1 of 25-26. What's presented in the slides today is demonstrating that we've now moved forward in each of the metrics, and we're delivering an improved service. We're not at the gold standard yet, but we are showing that improvement across the board. If I look at the slide deck, which I understand that you've all received your copy of, I can then run through. There we go. Just bear with me a second. I can run through each of the slides with the summary. So we have the summary now on each of those areas, which include continuing healthcare, children's complex.
Are you looking at what we've got, page 49? Is that where you're not able to share your screen, I assume, are you? No.
I don't know. Shall I have a look and see if I can? Because that might be easier.
And we're clear which page you're on. I mean, we do have the documents in front of us. So.
Share. Yes, I can share. Just 1 second. Is that sharing for everybody?
I don't see anything yet.
It will be up.
Will it? Okay, we'll wait a minute.
Great confidence.
Yes, thank you. I mean, it started, right? It started.
Is it sharing? It says the screen you are sharing, it's showing it is.
Oh, there we go.
He told you.
Is that okay?
Yeah, well, you know about these things, obviously. It's there. Thank you.
Okay. Yeah, so that was where I was just starting from. So it's showing you the CHC referral and eligibility and demonstrating, where we've come from December to now. So we've gone right up to Q4, which ended obviously on the 31st of March. and the CYP-CC inconsistencies in process. And what we've done around CYP-CC is we started a joint panel which covered VW, Reading and Wokingham from December. We've then evolved that process. That panel is still now running. So that's now addressing any backlogs and any inconsistency in approach regarding children and young persons continuing care. And then complex care is where we're looking at areas of care for the population that sit outside of both of those areas, CHC and CYP-CC, and delivering care for that population, and that includes things like neuropathways. The governance, we've worked with partners to ensure that we've got a good approach, that we are involving social care in decisions. We've also delivered a disputes policy, and we've implemented the healthcare contribution policy as well, which we've just done this month. So these were all pieces of work that I pledged in the December meeting that we would have in place, and they are all now in place. The healthcare contribution, which is the joint funding arrangements, is launched, but it will be an evolving process because we need to test it and work with it and make sure that it's fit for purpose. So that's kind of where we are with that. Obviously, our key objectives is to make sure that we've got a Bob-wide approach. So we're looking at what do we need to do. So there was some issue around was West Berkshire getting the same amount of referrals in. So what we're looking at doing is having an improved understanding of what that means, but we're also implementing a one-stop entry point for all of our footprint for Bob. So that means that all referrals will come into the same point and they'll all be treated with the same equity of approach. So we're sort of looking at doing that Bob-wide. We're addressing, obviously, any historical backlogs, and I can report that we're on track with that. And we're also at the moment developing a SharePoint for the children's area. Looking at fast tracks, we've noted now that there is an equitable approach, that is the same whether you're in Oxford, whether you're in Buckinghamshire, whether you're in West Berkshire area. And also the meeting all the national targets for BW now on that. So that's kind of where we are with all our metrics. Obviously, you've got more
We're on
details.
page 50 now. I think the pages aren't moving on.
And you asked her to go on.
But we are following you. I think we're on
Slow,
page 50 now. But we've got it in our pack, so if there's a problem.
You've got it in your pack, yeah.
I've got it in the pack. I think you're on page 50.
50. Is all I've got is my slide
sharing
deck. So
Your page 4.
yeah. Page 4. There we go. Fast track data. There you are. So if you look at the fast track data, you can see now that the regional data, there's no difference now between Oxford, Buckinghamshire and Berkshire West. The snapshot, Berkshire West is still slightly down. But if you look at all the metrics, there is an improvement from the December readings. I'll go on to page 5. So the CYP joint funding panel, which I talked about from Berkshire West, that's up and running from December. And that's now improved the relationships and the working together for children. And it still needs work in progress. We're not saying that this is where we need it to be, but it's much more improved from where we were in December. And then we have on 6, this was a slide that was put together by Kevin Gordon, together with Jenny and myself from the All Age Continuing Care, which just shows the positive feedback, the future plans, and about the enhanced support. So, it's a real positive story, and we're hoping to evolve the work on that as well to get it to where we need to be for the children. And that takes me into the summary of where we are. We've had a lot of enthusiasm from both health and social care. We've had executive level oversight to, work with us to make those improvements happen. We've aligned consistency across the ICB. We're now obviously working, because of the new arrangements proposed from NHSE, with Frimley. And just for the background information, Sarah's come across from Frimley and was doing anyway. So that's worked in quite nicely for us all. Desktop review of all the historical disputed case, that's happened, and that still continues to be work in process. Training and joint funding. So obviously now we've got the healthcare contribution. We now need to get together and do a training workshop on how that's going to work, and just keep that joint training on a rolling programme, really, to make sure that all people from the health side and from social care side are trained and sort of can efficiently use the national framework and the children's policy as well. Continued working with Beacon Advocacy Service so that the experience of individuals can be improved accessing CHC services. And as I've said, we're working on the development of a central hub for the quality assurance, verification, peer review, and to check the decisions are consistent across all areas of the BOP footprint, but also to have that central referral system so that everybody that accesses the service gets the same approach and treatment through the process. So phase 1 of that central process will happen in July, which will be for appeals, any previously unassessed periods of care, which is what PPOC stands for, and the ratification. And then phase 2 will be for fast tracks, referrals and disputes, and that's anticipated for the 1st of September. So that's our work plan. So what I've tried to do in a very quick nutshell is give you the steps we've taken to improve the metrics, and also looking at how we're going to continue to improve the service that we offer moving forward. So is there anybody that's got any questions or would like clarification on anything that I've brought up today?
Thank you very much. Thank you for that, Sarah. We've got Paul here, so I'm sure he will want to comment and see what he thinks about the progress. Thank you, Paul.
Thank you, Chair. Thank you, Daphne. Yeah, it's been really good working with you, and Sarah, looking forward to working with you as we go forward. Really appreciate it. I will give a slightly different account. I'm going to start with positives and then move into a bit of a challenge, if that's all right. So there has been greater pace from the team that's currently working on this. That's been really good to see. There have been some tangible changes. Disputes policy is a good example where we needed it, we've got it. It's good progress, and I'm grateful for it. And I do hear, although I'm not close to it, I do hear positive things from my colleagues in children's services about the new arrangements for children and young people. I've got 2 points of challenge. One is there is still a gap between referral rates and eligibility outcomes. There's still a discrepancy there. So whilst there is a degree of movement, we're still, feels to me, at the back of the pack in terms of outcomes for people. The second piece is, and we've been talking about this for quite a long time now, and we've had some promises from colleagues in the ICB. We are talking about Berkshire West data. Well, this group, I'm sure, would like to see West Berkshire data, and I'm told that that's possible, but it hasn't been forthcoming as yet. So we, within the local authority, will continue to raise challenge, hopefully appropriate challenge, because on behalf of the people of West Berkshire, we still think there's a gap.
Thank you for that, Paul. Do you have a response for that? Sorry, I called you Sarah. Daphne. Sorry, Daphne. Have a response?
No, I think I tried to sort of make that clear within sort of my presentation today that we've made steps to improve, but acknowledging fully, as Paul says, we are not there yet. So it is work in progress, and we are still moving and refining our processes to, continually improve the service. I think for the data, I can't really answer your question on data, but I can obviously talk to James Hughes, who's now he's my counterpart, so he's the operational director for all age complex and continuing care. So I do the clinical side, as Sarah will do the clinical side, and James will do the business side, so more of the operational side. So I suppose for me, Paul, it's about us probably having a meeting with James or yourself to see if we can get that query processed and moving on for you. I don't know whether you've had an opportunity to do that, Paul, but I can certainly make that happen if you think it would help.
We've raised this before. We've raised the data.
Yeah, Daphne, that's fine. I don't think we need a meeting. We have, so for the wider, the board's wider understanding, there is a kind of a strategic board which meets, which is chaired by the
mentioned in here.
at very senior level. And I think I've said it all of the recent meetings and will continue to say, please come and see West Berkshire. That's the place to raise it.
And you've said it umpteen times, and yet I'm surprised that we're still it's not being addressed. So that is a question, that why it's not being addressed when we keep raising it. Oh, your colleague has stuck her hand up. Yes.
Hi, good morning,
Sarah.
everyone. Hi, good morning, everyone. It's really nice to be here. Really nice to see you all. I'm looking forward to joining you in the future. In terms of, I think Daphne obviously just said that I've just come from Frimley, where I've worked for 4 years. So working with the 3 East Berkshire local authorities, Paul, we have been able in East Berkshire to draw down the data for the different local authorities. It meant quite a significant piece of work, data cleansing Broadcare, which is our IT patient record system, but that's being done. And so at the board meetings in East Berkshire and for Frimley, we do report down into the individual local authorities. So my aim would definitely be to do that, because that allows me to know where I need to focus my energies, and James will need to focus his energies. Just for everyone's awareness, obviously I'm in week 2 with Bob, so not new to CHC or children's continuing care. I've been doing it for 20 years plus, so I'm very experienced. I need to get to grips with the Bob system. James came in, I think, around January, and Tracy Brown, who's the director of all age continuing care and complex care, came in before that. So as a senior management team, we are quite new. We do know each other. We've worked together before. And helpfully, over the last couple of weeks, we've had our internal audit produced and given to us, which allows us to see what's happened. And obviously quite a lot has happened at pace over the last 6 to 12 months. There is a huge amount of work that still needs to be done, but the internal audit will help us focus on where to put our energies in terms of that. But Paul, please be assured that is definitely on my radar around drilling down into the data, so that we know where there's good practice and where we need to focus our energies from going forward in the short and the longer term. So you have my assurance that is something that I will be discussing and picking up with James over the coming weeks.
Thank
you, Sarah.
Paul's nodding his head. Thank you very much. Thanks for that. And Councillor Camden.
Yeah, just from so I'd like to know what I'm looking at, clarification perspective. If we take as an example your slide 3, just trying to understand what some of the dotted lines mean. So for instance, on slide 3 on the top bar chart, you've got a dark blue dotted line that's 5.2. That goes across, and then you've got a lighter blue line that's at 6.9. That seems to cut through Buckinghamshire and Berkshire West. And then another one at 14.5. So what are these lines represent?
So the darker blue is showing sort of the national average. And then so the lighter one is the regional.
Okay.
Yeah. So when you look at the regional, so if you look in the right hand side there, it'll say that in December we reported the 6.3 for new referrals, and then by quarter 4 we were reporting 10.1. So that shows that move, obviously, in the right direction.
Yeah, but the lines don't correlate with those numbers. That's why I'm asking the question.
Yes, because you're looking at
I understand the improvement.
Yeah.
Where you've gone from
so you're looking at the
10.1.
regional. So you're looking at the national average and then the regional average.
Right. So the national average is the 5.2. Dark blue line. Is that what you said?
That'll be the regional. The national will be the higher one, I would imagine.
Yes, it is. It is.
Yeah.
Okay.
Yeah. So the higher one's the national, so that's looking at all of England. The regional one's looking at the southeast, of which we
So
sit
again,
for an
just
HSE.
if you're looking at it, there's 3 lines, right? One's at 14.5. Is that the one that's national average? Or is the
14.5, yeah, that's a national average figure, yeah.
So well, Berkshire West currently is, instead of West Berkshire, is currently below the national average, is what we're saying.
Yes,
Yeah.
we've acknowledged it's
Yeah.
still, even though there's an improvement, we've still got some place to go.
Yeah. We've got way to go.
Fine.
Yeah.
I think that's the main message, isn't it? Isn't
Yeah,
it?
all I was going to say is maybe if we're going to present these again, maybe if you can put a legend or something just so that
Yes.
we understand.
Yes.
Because I'll forget by the time I walk out.
Yeah.
Yeah, we can
I mean, not all of us, I mean,
presentation.
thank you for that, Paul. Not all of us are that skilled in, sort of working our way around all these graphs and things. So the simpler they are,
Yes.
with more information.
Yeah.
That's generally speaking, over all the stuff we get from health, that some of us are more skilled in this than others. So.
See, acronyms, I'm still getting my head.
Oh yeah. Well, we're trying to give you a.
But an acronym gets to 6 letters, you've got to go.
Yeah, no, that's a good point. It keeps coming up, and Vicky does her best to try and give you a legend. So we're trying to get a legend together. Yes, Catherine.
Is there an acronym I can help you with, or have you
No,
got
because
more?
I think it's just an
on
ongoing
this
comment.
report, thankfully, they've all been spelled out at the beginning, which is what you should do in a
Yes.
report.
Yeah,
And some reports are saying not so.
Very
I
important,
assume.
because you don't want to keep thinking, oh my God, what's that? Yes, Catherine.
Yeah.
Thank you. It's not a question really, and just expressing disappointment really, because at the beginning here we're saying work is ongoing to review why Berkshire West has a variation. Because I was in part of the old Scrutiny Commission 5 to 10 years ago, and this was before Berkshire West CCG even, I believe, where we were bottom of the list nationally. And it just seems to be taking so long to get this sorted out. I really think we need to put a bit more urgency behind this.
Yeah.
If I can add a couple of comments. So one is entirely support your view, Alan. As I said when I spoke, this is the paciest I've seen the ICB, which is great. That is from a very low bar. The other bit that I'm a bit worried about is that, and we have crept off the bottom of the table.
Yeah.
We were like 1 or 2 up from the bottom. So there's, again, it's progress. One of my big worries in terms of the reduction of inequity or difference in outcome, let's say across Bob and the expanded Bob patch, is that what I'm seeing is actually the eligibility decisions for Buckinghamshire and Oxfordshire are creeping down more than the Berkshire West are creeping up. So there's a bit of a risk for us collectively that the outcome in terms of trying to be more consistent is that we all get fewer eligible people.
That's what you get with an equity of approach, where you try to reduce variation, is you try to give everybody exactly the same application of the national framework. And at the end of the day, that's what we're challenged to do, is to deliver the national framework. And we need to do that within Bob consistently across the whole footprint. So that means referrals coming in, getting the same consideration, getting an equitable service with the assessment, and then getting a robust outcome. It's MDT working, it's involving the local authority, and it's how we do that with that consistency of approach, meeting what is required of us through the national framework. And that's what we're trying to do. And we're trying to do it at pace as well.
Councillor Stewart.
I completely agree. Equity is absolutely essential. I'd be very interested to understand, if I pick East Sussex, seem to be doing quite well, if that's what we call this, in terms of sometimes higher numbers are not better numbers. So they are well above national averages, West Sussex too. So that equity within our area, I understand, but where is the equity between our area and other areas where the figures are so much higher?
Yeah, we're already speaking with Sussex. We're already speaking with Hampshire, Isle of Wight, and that's going to come probably as a stronger connection within the new sort of organisational changes within NHSE. So Tracy Brown, who's our Director of Nursing, is already having those conversations across those areas. And what we're hoping now is that we can sort of gather in working practice and do some read across as well. So to drive up not only just for Bob, but also for that southeast area. We are all obviously challenged as well from NHSE for the southeast to make sure that we're all in line. So that's all the systems that belong to the southeast. So we are also challenged at that level. I don't know. Oh, Sarah, I was just going to bring you in, Sarah. You're already there.
I'm already there. Yeah, I think if we looked at slide 3 and we look at Surrey Heartlands and East Sussex, and having worked in Sussex myself, there is a high proportion of ageing population. There is a high proportion of nursing homes within those localities, which will generate by nature, when someone goes into a nursing home, they will have a CHC checklist completed. The percentage of those that convert into eligible for CHC are smaller, so that you will get more referrals, but your eligibility rate will look less in terms. So and that's something that I certainly know that Surrey Heartlands and East Sussex have done deep dives on, and with NHS England supporting them on that, and why there's such a variation. Similarly, in East and West Berkshire, you'll have areas where there are more nursing homes. For example, RBWM, local authority, have a high percentage of nursing homes. So you will get more referrals coming in. Therefore, you will have a potential lower conversion rate into CHC eligibility. But I think the key here, and for me, the key has always been, is getting that message out, training our health and social care colleagues, doing that joint training, which is really, really important. So they understand when to complete a CHC checklist, they understand the assessment process and completion of a decision support tool, which is the bigger document that's used to determine eligibility, and that the consistency in decision making. And I think now that we are working Bob wide, I'm very aware up until recently we had separate teams working separate ways. So the aim from the senior management team here now is to have a Bob wide process, Bob wide decision making, to reduce any variation in eligibility decisions. So it's a real key focus, and I appreciate, we'd all want everything to work at super duper pace, but it takes time to embed it and to do it properly, because what we don't want to do is rush things and not have people trained, not have proper processes and operating processes in place that don't support any changes that we need to make, so that we make those people that are eligible, and quite rightly eligible as well. So I really want to offer my assurances that that is a key focus, and was a key focus that came out of the recent internal audit for the Bob wide service.
Okay, thank you very much for this. Do members have any more? Yes, Councillor.
I'm really pleased to hear that. When will we hear the following report with the next graph to show it's actually happened?
Well, I think we're going to have to bring this back again, obviously, because it's a work in progress, isn't it? So is that a sort of 6-monthly thing? Will it be back to December meeting? Would that be appropriate? Or was there room on the agenda? Or?
It's entirely up to you, or it could be dealt with informally throughout that time, keeping an eye on the performance, perhaps. I'm only mindful that the work programme
will get busier because of our responsibilities. What do you think?
Of course.
What would you advise?
I think it's something that the population of West Berkshire might be interested in.
Yeah. So it should be a public thing rather than an internal discussion. So it might not be a long item, and we might have some ongoing conversations between the meetings. So members are being kept up to date with what's going on, and so we keep pushing things forward. But then we have a sort of short public report, maybe it's on December meeting, just to sort of tell those members of the public that we hope for tuning in and listening, or going, iPlayer or whatever, not iPlayer, whatever it's called, YouTube. That they can actually access the information and keep up to date with what's going on. So I think, Paul, I think we'd agree with that. We all agree with that.
Yeah, quite happy to bring, further updates back in December. It won't be me, obviously, it'll be Sarah. If that's what you wish us to do.
We look forward to seeing Sarah in December, and thank you for the progress that we've had so far. We look forward to seeing more. So is that okay, members? Yeah.
Yeah.
Thank you very much for that, and we'll move on to our next item, which is thank you very much. Bye bye. See you again soon. Which is neighbourhood teams. So report back. Integrated English time. So, integrated neighbourhood teams. So we did have an item on this, I think, but I think this is an update, and I think with some additional information. So this is Helen to give us an overview of her report. Thank you, Helen.
Okay, thank you. So yeah, this is very much a work in progress, I think it's fair to say at the moment, and kind of emerging NHS policy and thinking. So we were asked to give an update. What I've shared is actually a recent board paper which went to the ICB board on the 13th of May, setting out our overall initial response to the neighbourhood working policy direction, and making a number of recommendations around a BOB level programme. So I'll come on to that in a moment, but just to say that the recommendations that were set out in the paper were supported by the board. So to give a little bit of background, so you'd asked about integrated neighbourhood teams. There's a lot of terminology in this space, and I think the terminology is still landing, to be honest. We talk primarily at the moment around neighbourhood working, and certainly the national rhetoric is using the term neighbourhood working now. Integrated neighbourhood teams are a possible construct within neighbourhood working, and similarly multidisciplinary teams, which is the other terminology, MDTs, I'll probably use as I go through, tends to be another construct focusing on supporting particular cohorts of patients. So in terms of the policy direction, so neighbourhood working first sort of came to the fore really in the NHS England planning guidance for this year. And then there was also some subsequent guidance issued around initial first steps that the NHS is expected to take over 25-26, as well as some supplementary guidance around how this approach might apply to children and young people's services, which I think it's fair to say we're still working through, given the range of other initiatives and partnership approaches that exist within that space. I think we can expect to hear a lot more about neighbourhood working in the forthcoming 10-year plan for the NHS, which we are expecting to be published over the summer period. But suffice to say that the approach very much also reflects the three shifts which are increasingly talked about in NHS circles. So focusing on shifting from a focus on illness to more preventative approaches, moving services from hospital settings into the community, and also moving from analogue to digital services. So these three shifts are very much the kind of buzzwords at the moment, but I think it's fair to say that neighbourhood working is very much part of that. Similarly, as has been alluded to earlier, we are seeing changes in ICB structures over the coming year and beyond, and a refocusing of the ICB's role. So I think at this point, it's difficult to say exactly where the development of neighbourhood working will land. I think the ICB will have a residual role in commissioning services that support people within their community, which is very much the ethos of this approach. But who does the delivery and how that happens, I think, is still remains to be seen, and it is being worked through. So I suspect this will be a topic that we may wish to come back to over the coming months and beyond. The initial guidance for 25-26 focused on 6 components. It was also focused very much on initially targeting neighbourhood working to meet the needs of complex patients, with a focus on avoiding admissions to hospital and supporting discharge. So very much in line, to be honest, with a lot of the integration work that we currently do through the Locality Integration Board, the Better Care Fund and other streams of work. But some particular focuses coming through. Firstly, focusing on access, so a stream around continuing to work to improve access to general practice. A stream around focusing on where people are presenting with acute needs, making sure that we have a joined up response to those needs, both from community services and broader intermediate care services. and also services such as the urgent community response, which is a service aimed at avoiding admissions for people whose health has deteriorated. Before people reach that point, there's something about how we plan care collectively, and how we work together in multidisciplinary teams to support the needs of complex patients. So this is where that MDT piece comes in. And so I think that sort of area is going to be the focus for the coming year. The broader neighbourhood working concept is intended to be more holistic than that. It's intended to support people sort of across the life course and all their health and well-being really at all stages of life and disease. So the broader concept would also think about prevention, how we interact with people within communities, work with the voluntary sector, community partners to really look to improve health and well-being. So kind of along the lines of what we've already been talking about through the community wellness prevention service, but very much in that. And I think that's where the neighbourhood term sort of comes in. It's working very locally with particular groups of patients to meet, or people to meet particular needs. And then the whole concept spans really supporting long-term conditions in an effective way, helping people to manage those long-term conditions and prevent deterioration in health, and then through to the more frail elderly population and how we can best support that population, maintaining health and well-being and avoiding admissions to hospital. So as I say, for this year, we're kind of in that third area, but the concept as a whole is much broader, and will sort of span, hopefully, how we collectively work together to support all groups of patients. So the other thing to say is this isn't new for us in West Berkshire, or indeed in the wider patch. So we've already talked about the community wellness service. We've also had a long-established MDT programme focusing on primary care and PCNs, involving BHFT teams, social care, and others to try and proactively work with patients to plan their care, and sort of keep needs as low as possible. I would say that was probably more active several years ago. It's still operating, but there's probably something about us refreshing and building on some of that. But equally, the point is that this isn't a new concept in reality, and there's already a lot of good work going on in all aspects of neighbourhood working that we should be able to build on going forward. So the paper proposed was focused really on proposing a BOB level work programme, aiming to set some key parameters around neighbourhood working, what it means for our population, and where the opportunities lie, and also making sure that we've got key enablers in place. So one key element of neighbourhood working, which I probably should have mentioned earlier, is around population health and really using the data that we have about our population to target and to plan care. So there's something about a BOB level, us making sure that we have that data available for partners to use locally, and that there's a consistent offer and capability to use that intelligence. Generally, there's something about, I said we've got areas of work, or areas of existing activity, but they may have dwindled slightly, they're fairly low scale. There's something about trying to kind of up the pace and focus on some of this work, and potentially have some consistency where that enables us to better engage some of the core services in supporting this way of working. But equally, even within the BOB programme, it's intended that we'll have very much local delivery. By its nature, neighbourhood working is supposed to be bespoke to particular populations and being able to respond to the needs of particular populations. So for all that we need enough focus and pace to drive it forward, we also need to have that local flexibility and local ownership of pulling partners together within local authority areas across place, and also in smaller sort of community or PCN level footprints. So with that in mind, we held a workshop at Berkshire West level back in April, which a number of people from West Berkshire were able to attend. I think we had a really constructive discussion about where we might focus some of our initial efforts, building on the guidance and the focus that I've already highlighted in the paper. So we talked quite a lot about that proactive MDT care planning space and how we can work together on that, how we might build on the community wellness outreach programme to think about prevention more generally, or to think about other services that may need to be delivered in an outreach way. So at the moment, we're focused on health checks. We've talked a little bit about vaccinations. There's probably other screening services, other opportunities that we could take a similar approach and deliver closer to communities, particularly where we're seeing that particular populations aren't accessing them as much as others currently. So we're in the process of putting in place some local work streams for on a West Berkshire footing, an individual local authority footing. We would look for those to be delivered and led through the locality integration boards. So we've already had a number of discussions, and I've met with the leads involved in that board. I co-chair that board, so that's helpful as well in terms of having a steer as to where we focus our attentions. But we're really keen to sort of re-galvanise some of the work of that locality integration board around this agenda. So in theory, hopefully we've got a good kind of mix of the Bob programme work that we need to do across Berkshire West, local work and ownership, but it is early days and we're going to need to work through how that works in practice and how we make sure that we get the benefits of the different levels of working and really deliver what we want to deliver through this work for our population. So I think that's probably an overview. I apologise, it is a very broad and still being defined concept. So I appreciate I'm probably sounding a little bit vague in some areas, but I think it is very much evolving and developing. And we do need to understand what is different from what we've done before, where there's an opportunity to build on things, where actually we maybe don't need to focus because we're already doing it. We need to recognise that as well. So lots of working through and conversations going on, and happy to come back, or it may not be I'm the most appropriate person, but to facilitate some sort of update perhaps from the locality integration board to the HOS going forward, if that would be helpful. But I've just tried to kind of give an overview of where things are at the moment.
So thank you for that, Helen. As you said, it's not new, but it's sort of evolved. It's evolved. Yeah, I mean, just to bring in members, I'm sure there'll be a few questions. I'm just thinking the proposed reorganisation of the ICB, is this going to affect in a negative way your ability to take these programmes and similar programmes forward? And also, obviously, this is all about health inequalities as well, isn't it? Bringing things closer to the people and making everything more accessible. But what about the capacity of our surgeries and, things like, I mean, I can remember hearing ages ago about trying to reduce readmissions to hospitals, which I think you mentioned, by making sure people have better aftercare when they came out, and maybe district nurses visiting, etc. I mean, in my own community, I'm aware that there is no aftercare when people come out of hospital. So, or that's my perception anyway, from the people that I know. So, yeah, the reorganisation, the capacity of the GP surgeries, have they got DNs that can deliver aftercare? Is there actually going to be stuff that can be done here? And of course, some GP surgeries maybe do it, but maybe not all. So is there going to be some equity?
Okay, so quite a lot of ground in those questions. So I'll try to pick up the points. So firstly, on the aftercare point, so discharge and supporting people post-hospital admission and avoiding readmission is absolutely a key part of this work. I think I've probably talked quite a lot about the admission avoidance, but actually a lot of our admissions are readmissions. So absolutely that is a key element. And that's reflected also in the work we do with the Locality Integration Board, and the BCF already is focused on sort of both ends, as it were. Capacity-wise, and the sort of point on primary care capacity. So the programme that is referenced within the guidance is Modern General Practice, which is a wider access improvement programme for primary care, which is already established. And I know we have discussed aspects of that in this committee previously. So that work is ongoing. But absolutely, we will be looking to facilitate all PCNs being involved in neighbourhood working, because I think primary care does have a key role to play within that. And then finally, with regard to the ICB changes, so I think it is going to be a tricky few months of possibly a more extended period as we work through those changes. But equally, we have to carry on with this work in the meantime. I think it's recognised that this is really fundamental to achieving sustainable services for patients going forward, and to addressing some of the issues that we've got around inequality and differences in access. Where I think I said at the beginning, where the delivery of some of this sits may change, but I think there will be a continued emphasis on neighbourhood working throughout the transition period, and I think that will be reflected in the 10-year plan and other documents and direction that come through during that phase.
Any members have questions? Another little one I had was about if we're going to have more local care and more returning people home, sort of as quickly as possible, etc. I mean, we're talking about probably a greater effect on carers, the people who care for these people in the community, the informal carers, whether they're sort of neighbours or people, So, I mean, I think we've got to bear that in mind, that maybe we need to be thinking about how we support our carers, and hopefully that will be part of what you'll be considering, that it's got lots of ramifications, hasn't it, really?
Yeah, I think that's a really important point and a good prompt. I mean, a lot of this is about working with communities, and that includes community organisations supporting carers. It should include people themselves and carers. So the carers' voice will be really important. But it's a good prompt that we need to keep that sort of front and centre as we move forward.
Thank you. I think thank you for that report. I mean, that's good to have that update. And as you say, we'll probably be hearing more about that in the future, but should we just wait and see how things evolve with Bob ICB and everything changing? I think we'll have to just see what goes on, and then, see when it's a good time to bring you back to give us an update on what's happening. Okay. Thank you very much. That was a very useful report. Thank you. Thank you. Sorry we're running a little bit late. Thank you very much. Thank you. Have we got we have got one mind. Okay, our next item is, we have to say goodbye to Councillor Stewart, unfortunately. Okay, sorry about that. Don't go too far. So the next one is item 9, and we have a report here from Regina Potter and Sally Moore from Royal Berkshire NHS Foundation Trust, and they will give us an overview of their report about their new strategy. Thank you very much and welcome. Sorry we're running a bit late. Hope that's okay.
No problem at all. Good morning. Can you all hear me?
Yes, we can. Thank you.
Brilliant. Nice to meet you all. My name is Georgie Potter, and I'm the Strategy and Partnerships Manager at the Royal Berkshire Hospital. And I'm here today with my colleague Sally Moore, who is the Head of Communications and Engagement. Thank you for having us here today. We're really pleased to be talking to you as part of our work to refresh the Royal Berkshire NHS Foundation Trust strategy to guide our direction as an organisation for the next 5 years. So our current strategy was last visited in 2022, and we're looking at it again now with changes to our healthcare landscape, with integrated care boards and systems now in place, and also the National NHS Review following the arrival of our new government last July, with the Darzi independent investigation and the 10-year plan coming out later this month. So we're now in the engagement phase for this work, which is why we're here today, which will be running from March through to July. So in the paper, I share some highlights from the previous phase, the planning and exploration phase, which may be of some interest to some of the committee. So over the last few months, we've revisited our progress against our current ambitions. We've reviewed over 50 policy documents, and we've listened to staff across the trust about what matters to them most as part of the What Matters exercise. So our strategy refresh provides us with an opportunity to look at what's working well, what we need to improve, and what our new priorities should be focusing on, especially as we work increasingly more close with partners across the system. In our engagement, it's important for us that our strategy is shaped by the patients in the community who use our services, our staff and volunteers, and our partner organisations. That includes HOSC committee members as both representatives of the local community and as partners in how we design and deliver our care. So today, we'd really like your input and recommendations into the RBFT strategic aims and objectives for the next 5 years. So the committee may want to consider our current strategic objectives in the appendix, but please do not feel constrained by these by any means. Thank you.
Thank you very much, members. Do we have Questions on the report? Councillor Stevenson.
Yes, can I mention, sorry, a couple of things. You identified several accessibility needs and you've put easy read formatting and paper-based options to avoid digital exclusion. I'm just congratulating you on including those two things. Thank you very much. The other one I'd like to ask about is under your current strategic objectives, which I think are all laudable, there doesn't seem to be any mention of mental health. And I wonder if it might come under your invest in our people and live out our values. Might you not include some mention of mental health there, or is that too specific?
So I think our overall trust strategy focuses more broadly on the trust as a whole, so everything including mental health. So then when we get below that, probably we've got a sister strategy called the clinical services strategy, which is probably where we would focus more broadly on that. So the clinical services strategy is how we want to deliver our clinical day-to-day things, and then specific teams and departments are invited to create their own clinical services strategy. So mental health is actually one that they have their own strategy, which will then feed up into the clinical services strategy, which feeds up into our overall trust strategy. So everything sort of filters down to the specific departments and areas, if that makes a bit more sense.
Can I just add also that we do work very closely with our partners at Berkshire Healthcare, who are the mental health sort of trust within this area. So as Georgie says, we acknowledge it in the report, but it is very much mental health is more Berkshire Healthcare, but it will be obviously fed into our report.
So, I mean, obviously, some of us have visited Royal Berks Hospital recently with a view to sort of making it clear to us, you know, what sort of state your building, your premises is in. So, you know, obviously that is a massive challenge for you. So we do, certainly I understand what you've got to cope with as regards the premises, and it's amazing what you do. I mean, this part of your strategy is your function, but I hope, you know, there might be a future opportunity for the members, the newer members, to maybe visit the hospital, because I think it's important that we know what we're talking about here, you know, that the hospital is really struggling. So that's just something going forward. But I was going to ask you about your plans to outsource certain outpatient visits to West Berkshire Community Hospital, or more of your practice, because I mean, I think there's so much more that could be done at our local hospital. That's within your strategy, is bringing things closer to home. I mean, you very much overlap with the last item on our agenda. I don't know whether you listened into that, about neighbourhood teams, neighbourhood working, you know, bringing things closer to home. And certainly from the point of view of what our residents would like, they would like to be able to access more care closer to home in our local hospital.
Yeah, and it's interesting you say that, because I've done several pop-up stands in West Berkshire Community Hospital, and that's something that I'm resoundingly hearing at West Berks, is that people would prefer to come to Newbury, even if it means travelling further, because they prefer Newbury Hospital, but also people that are local to West Berks just prefer to go to somewhere that's closer to them without having to come all the way into the RBFT. So it's certainly something that we're hearing, and something that will definitely feed back into the new strategy.
It is something that's absolutely on the, and I'm afraid I don't have the sort of information for West Berks. I've got some information for Townlands in Henley, which might not be of any interest, but just as an example, you know, we now run 30 different services from Townlands, and it's certainly, you know, as part of the government agenda as much as ours, to get care closer to home, delivered closer to home.
Yeah, good. That's great. Obviously, you need the cooperation of your consultants and your staff to do that. So obviously that is happening. So that's very much part of your strategy. So that's very good to hear. And I don't know whether you heard any of our discussion, but we were talking about, you know, sort of aftercare, what happens when people are discharged from hospital, and what we do to prevent readmission. So do you think you have good links with your local GPs to actually make sure that when you're discharging patients that they are getting some sort of aftercare? Is that a problem?
we've got extremely good links with our GPs. Until recently, my work straddled the ICB as well. So we did a lot of work with primary care. So yes, those links are there and they're strong.
Members have anything they want to? All right, I mean, there was just something else I was going to just be, oh yes, Councillor Stevenson, yes?
Sorry, in our pre-meeting, Vicky raised that she wanted to ask about people living with multiple conditions. Have they taken that into their trust focus and equality of opportunity?
Within
their overarching aims.
The aim, equality of opportunity.
And people living with multiple conditions.
Special services, what coordinating the services, how you care for people living with multiple conditions.
Yeah.
Is that something, because obviously, making life easier for them. Because obviously one individual can be seeing a multitude of practitioners. Yes. So how are you sort of bringing that all together to make it easier for the family?
Yeah, and I think that's something else that we've been hearing a lot, is that sometimes there is disjointed communication in between services. So that's definitely something that we want to try and improve with the next strategy, to make sure that people are sort of telling us one thing once to improve that sort of holistic care over the board. And I think equal opportunities probably sits under our people and live out our values strategic objective, which again, I think we're doing a lot of really good work in that so far. But of course, there's always more work to be done. So that's why that strategic objective is probably going to remain the same with different aims, because there's always more that we can do in that one.
Thank you very much. Thank you. So I don't think we've got any more questions for you today, but we certainly sort of found your report interesting, and it's good to keep in touch, and we will be hearing further about what's happening with your strategy in future, I'm sure. So thank you very, very much for attending today.
Lovely. Thank you very much.
Thank you.
Thank you. So we move on to item 10, where we have our Health Watch update from Jamie Evans. And Jamie is the Area Director from Health Watch West Berkshire. So Fiona, who's our local manager, isn't able to be here today. So Jamie is attending in her place. Okay, is that correct, Jamie? Yes.
Yes, that is correct. Fiona is off this week.
Thank you. Okay, so would you like to update us? I mean, we have seen your latest newsletter from Health Watch, which was actually quite informative, and I did send it round to members, but I'm sure you'll be updating us on what you're doing.
Yeah, so the key thing at the minute is we're in the middle of getting our annual reports done. So every Health Watch has to do an annual report. It's due at the end of June. So we'll be publishing that at the end of June. So that's about the 24-25 financial year. The other side of that is that we have a work plan every year. So our work plan for 25-26 this financial year has been focused around providing people with as much information to take agency wherever possible within their health, their own health. So what that looks like is two key streams. So there are 4 in-person events that West Berkshire Health Watch are hosting across the year. So they had one last week. They had their first one over in Thiel. They're doing those at various locations across the West Berks area, and they're designed to have a specific topic for each one. So the one last week was health management in golden years. And the one that it was due in September is support for all. So that's about overall health management and how other things like budgeting, nutrition, stress management fit into people's health and well-being. The other side of that, as you just mentioned, is the newsletter. So we're looking at a different process to try and get as much information across to people as possible. One of the things that we hear quite regularly is that people aren't necessarily aware of what's happening on the national stage. They're not always aware of what's happening at a local stage either. So we're trying to pull that together and then also tell them what we're doing. And then at every point during that process as well, we're asking people to get involved and feedback to us and tell us what their experiences are. We had a couple of reports in West Berkshire that were published in the last couple of months. So one of them was called Everyday Heroes. That was about dementia and carers' experiences of isolation and various other issues as carers. And then the other one was called Maud, but still isolated, and that was about the Bargee community. So that was where the team went and did some outreach about their experience of accessing GP services and registering for GP services. Somebody mentioned earlier about digital exclusion and digital inclusion. So the digital strategy is the newsletters to try and be as informative as possible and to try and get as many stories in front of people to get them aware of what's happening, to get them thinking about things and telling us stuff. The events and the regular drop-in sessions that are done as well, they are to try and capture as many people as possible who might not access through digital methods. Particularly across, some of the wider communities of West Berkshire as well. So that is part of the reason why they are at 4 separate locations as well, to try and get as many people involved as possible. The general gist with that, again, is, like we said, just to try and encourage people to take more agency in their own care. So we hear from people that they're not aware of services that are available, that they don't know to ask about something, that they think that they naturally assume that something isn't available. So we're trying to encourage them to be more aware of those things and to use services that are available and to feedback on those services. And then additionally to that, there's the ongoing Women's Health Hub issue. So that's been rattling on for over a year. That was a Bob initiative that was partly funded, well, it was funded by NHS England. NHS England give ICBs across the country money to deliver a women's health hub. That is in a process of that broadly finished at the end of March. And ICB is now looking at a women's health strategy. So we've been encouraging them to look at that and to involve the public of West Berkshire, so the women of West Berkshire, in talking about what it is they need and what would be helpful in those strategies. And as mentioned about things like the West Berkshire Community Hospital, people want more accessible locations that they can go to for services that are more frequently available. So it's things like that that we are pushing for as well. I think that is broadly it from my side. So if there is any questions, I'm happy to go through wherever I can.
Very much, Jamie. Paul has a question.
Jamie, thank you. Just a minor question, I guess. You talked about some of the reports that you have published. I was just on the website. I couldn't, I'm sure other organisations referencing the report, put together a response, which I think was a helpful response, highlighting sources of support, as well as some concerns about the sample size for everyday hearers. But I can't see any of that published anywhere within the report or elsewhere on the site. So it does. I'm asking the question: what's happened with that feedback?
That feedback should be updated into a report that will be re-uploaded in the next week or so, I would hope. So that's usually ideally we would get the feedback and include it in the report at the time of publishing. That didn't happen in this instance, but you should see it in an updated version of it fairly shortly.
Thank you.
It's good to hear that Health Watch is getting out into the community. I mean, I know they have a very, very small staff. I'm wondering whether because they used to have champions, sort of volunteers that helped when they did community engagement. I wonder if that's a project that is still there, or whether there are any volunteers assisting Health Watch. And also, how are you picking up your priorities? Are you getting good contact from the public? Are people using you? Because that's always an issue with Health Watch, about people's awareness that you exist and what your role is, which actually is a very important role.
Yeah. I mean, I think we're trying to provide people with more clarity on our role, because the patient voice market is quite cluttered. We've got a good level of engagement, so that will come out in the report as well. It could always be better, but this is one of the reasons why the in-person events are very important as well. So So from the strategy, from the survey responses and the surveys and questionnaires that were filled out on the day of that event, we've got 75 people so far have provided their experiences of health management in their later years. So there are ways around it. We are always compromised by the fact that it is a very small team. There are 3 staff members, none of whom have full-time hours. So our ability to manage volunteers is quite compromised generally. We are hosted by an organisation, a charity called the Advocacy People, and the Advocacy People have been investing quite heavily in their volunteer strategy across the last year. So they're putting in place a new portal which will be useful for helping us manage volunteers. So they've also been refreshing their strategy. We've been refreshing our local strategy. We're hoping to tie those together so that towards the sort of second half of this financial year, we'll be able to get more volunteers involved and get more community support out there. But it's just been challenging because, you know, Fiona is the lead officer. She's also the comms officer. She has a 24-hour week contract, so her ability to then manage volunteers on top of that is not great at the minute, and that's where we're hoping where those facilities will come in and help.
But you used to have a program of what we called Enter and View, where you went, visited where there was areas of concern, say GP surgery, oral care home. You had the facility to go and with trained volunteers to actually go into those places and do a report and then revisit. So obviously with your present capacity, you're not able to do that.
With the present capacity, we would go in and do an enter review if it was something that we were requested to do. But a regular program is not something that we've been able to maintain. But part of our volunteer strategy is a Berkshire West wide enter and view team of volunteers. So that is something we are hopefully looking at again towards the back half of this financial year, is trying to get a team in that can do regular enter and views, because we think it's important that people don't see it as a punitive exercise. Enter and view is actually an opportunity to also say what's going well, show good practice, share with the public, you know, where their services are innovating and working hard, working in partnership. So hopefully, again, with that later in this financial year, we'll have the ability to invest more in that.
That's good to hear. And when did you say your report is out, your annual report? Is that due?
Due for publication at the end of this month.
Okay, so quite soon.
Yeah, that's why Fiona's taking a break right now, so that she can come back and finish it as much as possible next week. So it's all go at the moment.
So do we get that sent? We should get that sent to us. We should receive your report. Will that be sent to this committee?
Yeah, so it'll be published online and it'll be shared widely with as many of our contacts as we can.
We can share it. Okay, we'll make sure that we access that and we share it with members of this committee so we can see an overview of what's going on. Members, any questions? No, I didn't think so. So thank you very much, Jamie. Thank you very much for listening into the meeting. I think you've been here for the whole meeting, I think, haven't you? So I hope you found it useful. Thank you very much for your attendance.
I have actually, and I think it's really good to be able to show the public that these things take place and that there is scrutiny and that there is investment. And I think it's a really worthwhile thing to highlight. So something that Fiona will include in the newsletter that we send round at the end of the month, just to say that these things happen and they are important and they do work.
That's very good, yeah. Well, this is a public meeting, but heaven knows, I don't think anybody's listening in, but hello, if you are. But it would be good to think that people do access this and know that it's available, can go off online and view in their own time. Yeah, because we want people to know what we're doing, don't we? Both you and I do. Yeah. So thank you very much again for your attendance, and we'll see you, and we'll see hopefully Fiona next time.
Yes, thank you guys. All right, thank you. Bye bye.
Thank you very much. Bye bye. Bye bye. Okay, so next item is item 11, which is update on task groups. So members will be aware that we had a task group looking at children's mental health and emotional well-being, and members of this committee sat in the task group, myself, Councillor Jeffrey, Dr. Stevenson, Councillor Colston, who's not here today, and also Councillor Taylor, Dick, and Councillor Paul Dick. So they were the members of the task group. We had 3 meetings and an extra one just to sort of look at what we found. And I think we all found it an extremely worthwhile exercise. The draft report is going to be brought to a future meeting of this committee, so you'll be able to see what went on and what we talked about. And I think it goes to it. So it has a little process. At the moment, all witnesses contributed, and the contributors have an opportunity to see the report. So it's sort of passed out to them for verification, and then we'll go to corporate board and then back to this committee. So yes, so thank you for everybody that took part. It was a valuable exercise. In particular, I'd like to thank Vicky, who pulled it all together, contacted the witnesses, made sure the right people came along, and then did what we think is an excellent report. So hopefully you'll get the opportunity to see that to distant future, if I just don't know. Or we're going to have a special meeting.
Members wanted not to wait until September.
That's right. So we're hoping to have an extraordinary meeting of this committee to actually verify that when it comes back. So because there are some important recommendations on it, we didn't want them to just sort of float away and leave, that we wanted them to be passed on to the appropriate bodies. So we thought we might try and so we're getting a difficult time, aren't we? So it might be July-ish.
Yes, I'll make contact with them.
So we'll have a look. So you might be asked to attend a meeting. It's a big July, so hopefully people will be available, because I know it's a difficult time. Okay, so the next item is item 12. We're going to look at the draft work programme on page 73. Any comments or any proposals for anything that you think needs to be looked at or added to the work programme? If there are any new items, they go through a prioritisation tool. So Vicky will sort of do that to give them sort of see where they come in the scheme of things. So you're all welcome to put some issues forward if you have them. But any comments or questions?
We agree what we're doing on oral health, whether that time, did we agree what we're doing on oral health, whether that time scale has changed?
That's coming to the December. Well, we've already proposed that we want. It comes back to a December meeting, I think. Is that right? It's got it down. Yeah, because Vicky has to, yes, there are some things she still has to do, but I think that's coming back in December.
Okay.
But we did agree that we wanted
yeah.
Yes.
Well, you alluded to it earlier, this reorganised kind of major reductions in expenditure and reorganisation of the ICB. I think you ought to have some kind of report to come back here to.
Well, that is what's happening in that regard at the moment. Oh, Helen's popped up. She heard that. So as regards, I'll let Helen comment because obviously she's the expert here. But from my own point of view, myself and Councillor Stevenson are a member of the Joint Overview Health Scrutiny Committee, which is a sort of regional thing, and the members of that, the sort of acting chair, who's the vice chair, is trying to convene a meeting and get Bob ICB involved in that, just so that the members of that overarching group can be aware. And obviously, before that happens, we'll be asking for this committee members to feed in that says, do you obviously have something to say? I'm sure, Helen, yes?
No, it was only to reassure you, I guess, as we move through that transition, engagement with HOSCs will be part of our process. So it may be initially through the joint meeting that you're referring to, but we absolutely would be looking to bring updates to HOSC as part of the engagement plan for the transition once we know more about it.
Thank you. So yes, that might well be sort of included in this work programme, just as a sort of, yes, Paul.
So I'm mindful Vicky, yourself and Melanie and I met and we talked about some of the adult social care things that we thought could come forward. Where are we with that process?
We agreed for you to have a meeting with Councillor Vickers.
Have a
And
piece today, yes.
some of those items I've noted down. So the my next sort of responsibility after today is really drill down the work programme based on our conversations and the key items that Scrutiny can have some impact on, as well as I have quite a list of other things that members have come to me about that need to be prioritised as well. So I'll share that with members as soon as something a bit more.
Okay, yeah, I'm aware that we said we'd have a meeting, so I was going to ask about that actually, just so we could. Yeah, so there's lots of, I think because of the change in this committee, I think there's a lot of things that Vicky has to think about. So we haven't, a lot of things have come forward. So, but where programme is looking a bit blank because of that. It doesn't mean there's nothing coming up. I think Councillor McRae, you said something about vaccinations, thinking that was something.
Well, we covered that earlier.
Yeah.
I was a bit alarmed when I saw there's a report in the press about very low vaccination rates across the country. We had the data today which showed that perhaps the West Berkshire things aren't quite so bad. So I was quite concerned about that.
And we had a question from one of our members, and it was Councillor Benniwell, about the law centres, which I think we've had an email from Paul with information about.
A short email, because there's not an awful lot of substantive news, but I've explained where we are at the moment.
There's some information about that. So, anyone on the work in progress? Okay. Thank you very much. I think that's all our business, unless members have anything pressing they wish to say. No? Okay, thank you very much for allowing me to close. Thank you very much for your attendance and for all your contributions. Thank you. See you. It's been a while. It's going to be late. Thank you.